So after going through heart failure, then the arrhythmias of atrial arrhythmias, that is atrial flutter, atrial fibrillations, various treatment including thrombolytic treatment, which is used for or which is very essential during atrial problems. Let us go ahead for the next, that is ventricular arrhythmias and the consequences and their, as I told you again, this is based on the guidelines, and these guidelines are based on the details, as we have seen, then class of recommendation and level of evidences for the strategies. What are the basics are utilized, they are given in this slide. So let us go for the details. So these are the 2017 guidelines for the management of patient with ventricular arrhythmias and prevention of sudden cardiac death, SCDs. Now in that, let us see one by one what are the guidelines for the general evaluation for a patient with documented or suspected ventricular arrhythmias. So the class 1 recommendation is go for the patient which are admitted into hospital with syncope and ventricular arrhythmia has been documented, then should be hospitalized for evaluation, monitoring and management. That means this patient should be, whenever there is a syncope, this should be admitted to hospital and then all the tests should be performed. Then next into this is go for 12-lead ECG and exercise testing. So these are again highly recommended one. The class of recommended is 1 and there is no randomized like thing. So this is the best recommendation. Go for 12-lead ECG and check various ECG parameters and accordingly go for decision making. Now if the patients are ambulatory, then check with the ambulatory electrography. Ambulatory monitoring is also useful to evaluate whether the symptoms like palpitation, pre-syncope or syncope, they are caused by ventricular arrhythmias. Syncope is fainting like thing, that is feeling, before fainting people feels slightly black or darkness or there जिसको हम बोलते हैं कि अंधेरी in Marathi the people call. So that means this kind of thing is there, becoming almost less sense for getting blank for some time. So these are the syncope. Pre-syncope, again slight such feelings are there, but do not go into this. Then those which are having implanted cardiac monitoring, again go for the ECGs in this patient. So ECG will be important. Then next is the patient which are known or suspected arrhythmias, then go for non-invasive cardiac imaging. There are various tests are there, we call it as a CT angiography. Example of this is, so go for CT angiography and check the imaging and accordingly find out the reasons. This will give the reason whether there is any kind of other heart diseases problem or is there any angina or myocardial infarction like situation. Check it out. If it is so, then accordingly simultaneously it can also be treated. Then go for various biomarkers these are again having important measurement of natriuretic peptides, that is BNP or N-terminal pro-BNP. We have seen about it earlier. So go for that and accordingly predict whether the patient may have chances of sudden cardiac death, because if it is increasing too much BNP or N-terminal pBNP, then there are chances of sudden cardiac death because of severe arrhythmia or sudden cardiac arrest. So these are the things. If death is there, nothing can be there. If arrest is there, there is a last chance the patient can be recovered. Then if it is immediately taken care of. The patient and family members whom genetic testing for the risk stratification is done for this sudden cardiac arrest or death, it is recommended genetic counseling will be beneficial. So there are some people are having genetic that their father or grandfather or mother they had some problem and genetically they are more prone to have these diseases. in these people we have to go for this genetic testing. Then invasive cardiac imaging, the cardiac catheterization or CT angiography can be done, and with that we can determine that whether there is any ischemic heart disease is present, and accordingly take decision on the just like whatsoever we have seen the decisions in angina and myocardial infarction, accordingly go for the revascularization. Then electrophysiological studies, they are checked in the patient with the ischemic cardiomyopathy, NICM or adult congenital heart diseases, that is non-invasive cardiomyopathy, these are checked, non-ischemic cardiomyopathy and adult congenital heart diseases who have syncope or other arrhythmia symptoms and who do not meet indication in the primary prevention of the ICD. Then electrophysical studies can be useful for assessment of the risk for the sustained ventricular tachycardias, and who meet the treatment for this ischemic cardiac diseases implantation, then go for electrophysical studies and check it out. Electrophysiological study is not recommended for the risk stratification in the ventricular arrhythmia in the setting of long QT syndrome, catecholamine-rigid polymorphic ventricular tachycardia, short QT syndrome. In that cases it is not beneficial, rather it is harmful and it is not recommended. What are various treatments which are there for arrhythmias? We have seen various anti-arrhythmic drugs earlier in pharmacology. Let us see how these drugs are to be used. So recommendation is for prevention of sudden cardiac death with heart failure medications. So what are these heart failure medication? We have seen this where because of arrhythmia also there can be decrease in the cardiac output because the ventricular beating is so fast that it is not allowing proper ejection, and therefore there is a decrease in the ejection fraction. So where there is a decrease in the ejection fraction, or we call it as a heart failure with reduction in the ejection fraction, we call it as a HFrEF, and the LVEF, that is left ventricular ejection fraction, is less than or equal to 40%. So what is the treatment? Beta blocker or mineralocortical receptor antagonist, that is we call it as spironolactone is the drug, either any ACE inhibitor or any angiotensin receptor blocker or ACE receptor neprilysin, that is ERNI we give, that is angiotensin receptor and neprilysin receptor inhibitors, they are given, and accordingly any treatment can be done. This is having the number one class recommendation or the best recommendation, and even level of evidence is the best in that class. So this is the best treatment it is there. Then next is the surgery and revascularization procedure in the patient which are having IHD, that is ischemic heart diseases. So in that we can have both our class of recommendation. One that shows patient with sustained ventricular arrhythmia and those who are survivor of sudden cardiac arrest should be evaluated for ischemic heart diseases and should be revascularized as appropriate. Patient with anomalous origin of the coronary artery suspected to be cause of sudden cardiac arrest, there should be repair or revascularization is recommended. So these are having ischemic diseases, so immediate treatment for ischemia is to be taken. Surgery for arrhythmia management, we have seen various treatments, ablation and all other. So what treatment which can be there? Earlier in atria whatsoever we have seen, similar here it is. So patient with monomorphic this ventricular tachycardia which is refractory to antiarrhythmic medications, and there are attempts to at catheter ablation, surgical ablation may be reasonable when it is not controllable. The first preference always is, we have seen this, the first preference is always is there for the pharmacological management. Then autonomic modulation in the patient with symptomatic non-life threatening ventricular arrhythmias, treatment with beta blocker is the reasonable. In patient with the ventricular tachycardia or ventricular fibrillation, should or storm in whom the beta blocker and other antiarrhythmic medication or catheter ablation are ineffective, are not tolerated or not possible, cardiac sympathetic denervation can be reasonable, but it is again not as a very good this one, because it is having low incidences of or low recommendations are there. Then acute management of specific arrhythmias, these are having this guideline in case of acute. When it is acute, their person is admitted, what is the treatment. Then class 1 is patient with cardiac arrest, the cardiopulmonary resuscitation to be the CPR is very, very common term. Those who wish, they can just search it, CPR techniques. The pressing chest and giving respiration is the immediate treatment, because I told you there is a difference between this sudden cardiac arrest and sudden cardiac death. Is cardiac arrest means it is known that heart has stopped, but there is a little chance that the person can be recovered and the efforts can be made. So we call it as mouth to mouth respiration, and all this, everything goes, is we call it as a cardiopulmonary resuscitation. It should be performed according to the published basic and advanced cardiac life support algorithms. So this is the best treatment, because there is no other thing immediately can be done. Then second is patient with the hemodynamically unstable ventricular arrhythmia that persists to recur after a maximal energy shock. Intravenous amiodarone should be administered to achieve the stable rhythm after further defibrillation. Defibrillation again are the machines. These are the defibrillator machines are there. Electrical currents are applied, and on that basis it is there. Then the next one again, which is having class of recommendation 1 and level of evidence, is the best, that is A class. We have got patients presenting with the ventricular arrhythmia with hemodynamic instability should undergo direct current cardioversion or direct shock like treatment, as we have shown. Cardioversion means DCC we call it as a direct current cardioversion, where this chest current are applied. You might have seen that two press like things people are pressing. So this is direct cardioversion is there. Then next is again class of recommendation is 1 and level of evidence is which is non-randomized. Patient with polymorphic ventricular tachyarrhythmias or ventricular fibrillation and having ST elevation, myocardial ischemia, infarction. Then angiography with emergent revascularization is the important treatment. Then lastly is the patient with wide QRS tachycardia should be presumed to have ventricular tachycardia if the diagnosis is not clear. So only on the basis of wide QRS it can be considered as a tachycardia, and treatment should be there. Acute management of specific ventricular arrhythmias, again the next are the list comparatively having second recommendation or second class of recommendation. So we have a patient with hemodynamically stable ventricular tachycardia. Administration of intravenous procainamide can be useful to attempt to terminate the ventricular tachycardia, and it is level of evidence is one that is everybody has found it is good one in most of the trials. Then second A, again it is a second line treatment. Patient with the witness cardiac arrest due to ventricular fibrillation or ventricular flutter and polymorphic ventricular tachycardia which is unresponsive to CPR, then defibrillation and vasopressor therapy should be immediately done. Intravenous lidocaine can also be beneficial. Then next is class B, randomized, means it is again in both cases it is a second best option after the class of recommendation 1 and level of evidence A. This is second best option. Patient with polymorphic VT due to myocardial ischemic beta blocker can also be useful, and then repeatedly recurs despite direct current cardioversion or antiarrhythmic medication. Intravenous beta blocker can also be useful. In patient with cardiac arrest, administration of epinephrine 1 milligram every 3 to 5 minutes during CPR can be reasonable. So these may be, again you will find it conflicting, but very important to understand. The point number 10 and point number 9, they are opposite to each other. Point number 9 says that you should use beta blocker, and point number 10 says that you should use epinephrine, which is beta 1 agonist. So in what cases particularly you should understand this? When there is a recent myocardial infarction and already treatment is going on, cardioversion has been done, antiarrhythmic medication is there because there is already revascularization is done. In that cases beta blocker should be given, because after myocardial infarction there are very strong ventricular tachycardias are there or tachyarrhythmias are there, which we call it as a ventricular tachycardia or ventricular fibrillation storm, because they are very severe one. So that has to be controlled, and it is because of the sympathetic overactivation. So in that case we need to give beta blockers, or it is helpful. But already there is a cardiac arrest, that means heart is not pumping, and it has stopped just now, recently, few seconds before. So in that cases we have to initiate the pumping, the heart activity or pumping activity. So in that, and somehow CPR it has not responded well. So or along with CPR it can be given. So in that cases we can give epinephrine. So these are two different conditions, and that makes the things or it should be clear to the people. Then next class 2B, which is class level of evidence is B. In the patient with hemodynamically stable ventricular tachyarrhythmias, administration of intravenous amiodarone or sotalol may also be considered to be attempt to terminate ventricular tachyarrhythmias. There are cases where there are no benefit, although, and it has been found in various studies. The level of evidence shows it is A. That means in all these studies, or in most of the studies, it has shown that there is genuinely no benefits. So a high dose of epinephrine has no benefit, which is greater than 1 milligram bolus. In patient with refractory ventricular fibrillation, which is not related to Torsades points, administration of intravenous magnesium is not beneficial, and there is no point in giving it, it is useless. And in other cases there are things that is which causes harm, and it is a class 3 recommendation. That means it must not be done, it should be avoided as far as possible. So with suspected acute myocardial infarction, prophylactic administration of lidocaine or high dose of amiodarone for the prevention of ventricular tachyarrhythmia is potentially harmful. It can stop heart. Patients with wide QRS complex, tachycardia of known origin, calcium channel blockers like verapamil, diltiazem, they are potentially harmful and should not be given. So it is again important, if it is a wide QRS complex, then it should not be used, it should not be given this calcium channel blocker. Otherwise we find, if you remember atrial tachyarrhythmias, we have seen that the first preference was calcium channel blocker and beta blocker. So here we cannot give, particularly when there is a QRS complex tachycardia. Then next in this is, what is the algorithm? Let us see the algorithm. So when there is a monomorphic ventricular tachyarrhythmias is there, so let us see what should be there. So it is sustained monomorphic ventricular tachyarrhythmias. Check about hemodynamic condition. If the patient is hemodynamically stable, then go for checking with 12-lead ECG and go for the next treatment. But if the patient is unstable hemodynamically, blood pressure is not there, then immediately go for direct current cardioversion and acute treatments, so that you can recover that. Hemodynamically unstable means the blood pressure has fallen, the systolic has fallen below 80 and diastolic has fallen below 60. It is very dangerous, so immediately take actions. Now if it is stable, then go for 12-lead ECG, check history, go for physical examination and consider the disease specific ventricular tachyarrhythmia. As example, if it is because of ischemia, if it is because of failure, if it is because of or release of more adrenaline, etc., whatsoever it may be. So go for accordingly that. Structural heart diseases, yes or no, check. If these are structural heart diseases, then check out what are the kind of it is, and then first treatment is go for cardioversion again. If it is a structural disease, then go for intravenous procainamide. Just now we have seen class 2A drug, and third is intravenous amiodarone injection. If there is a termination of ventricular tachyarrhythmias, if it has happened, then very good. Then go for check out if there is a termination, then therapy guided by underlying heart diseases, go for it. Okay. If not, then again go for cardioversion. Now in that case, if there is a ventricular tachycardia till it is terminated there, and if it is still not there, then go for sedation, anesthesia, release, antiarrhythmic therapy options, repeat cardioversion. Patient has to be anesthetized and try it. That is only the treatment. And if it is not there, then go for catheter ablation. That is, you remove the part which is responsible for arrhythmias. Now, if there is no structural diseases, and check the ECGs, ECG will show you what kind of it is, and check the morphology for idiopathic ventricular arrhythmias. Then if it is there, then go for verapamil, or go for these beta blockers for acute termination of ventricular. If it is effective, fine. If no, then go for cardioversion. Then go for maintenance therapy for the prevention of recurrence of that. So give the maintenance therapy, and if it is, you find that during maintenance therapy it is problem, it is not controlled, that is maintenance is usually verapamil or beta blockers. If it is not working, then go for catheter ablation. Again, I told you what catheter ablation is. We have discussed it. Catheter is inserted near the point from where the impulses are coming, which are extra impulses, and that portion is removed with help of that microsurgery, and only small portion is removed. Thus, there are reduction in the impulses generation from that area. Then next is ongoing management of ventricular arrhythmias. What way you will be doing it? What are the ways by which you can do it? So these are particularly for cardiac arrhythmias. So ongoing management of ventricular arrhythmias and sudden cardiac risk are related to specific disease status. So what are these? Go for the secondary prevention for the sudden cardiac death in patients with ischemic heart diseases. So prevention of sudden cardiac death, because on the basis on the history or on the condition, the clinicians can think or can understand that the patient may go for sudden cardiac death, and before that what's your treatment. So before going for sudden, because after death there is no treatment or there is no use of any treatment. So here what sort of treatments are there which has to be for the prevention of sudden cardiac death are there. So patient with ischemic heart disease who either survive sudden cardiac arrest due to ventricular or tachycardia or ventricular fibrillation, or they are experiencing hemodynamically unstable ventricular tachyarrhythmia. So in that cases, or if they are stable, then do not, which is not due to reversible causes, then ICD is recommended. If meaningful survival having greater than 1 year is expected, then go for this intracardiac device. You put stent or something, or you put the device which will be controlling the activity. The transvenous ICD provides intermediate value in the secondary prevention of SCD, particularly when the patient risk of death due to ventricular arrhythmia is very high and the risk of non-arrhythmic death because of the cardiac or non-cardiac is low. Based on that patient burden of comorbidity and functional status, it has to be done. Then again, class 1 recommendation: patient with ischemic heart diseases and unexplained syncope who had inducible sustained monomorphic VT on electrophysiological, then they can go for this. So how we do secondary prevention? That is secondary prevention in case of patient with ischemic heart diseases. That is, if there is a person who are having survived from the sudden cardiac arrest, who was almost died, but because of maybe CPR or maybe immediate medications the patient is survived, then check what is the reason. If it is ischemia, then check immediately revascularization to be done. Then if it is yes, then go for that. If there is no ischemia or no requirement, then they are the candidates for the intracardiac devices, then various classes are accordingly go for that. And these ICDs, that is implantable cardio defibrillator or devices are there which causes defibrillation, so go for that. And then next is the if you feel that in that ICD cannot be implanted because of one or other, then go for the treatment as per the guideline they are guiding, as per the guidance of the guideline derived management treatment, okay, or guideline directed management, and the treatment can be done with that way. And if the patients are not having any kind of chances or any kind of episode of sudden cardiac arrest, in that cases, if they are having syncope, then check out if the left ventricular ejection fraction is less than, usually this happens syncope when ejection fraction is less than 735. If it is yes, then go for again this implantable cardioversion devices. And that then if there is a if the ejection fraction is more than 35, then go for various treatments and check out if it is inducible this ventricular tachyarrhythmias. Then if it is yes, then go for again ICDs, and otherwise go for extension of monitories and go for other treatments. So this is how we are going for secondary prevention for the patient with this IHD, that is ischemic heart diseases. Now secondary prevention of sudden cardiac death in patients with ischemic heart diseases where there is a coronary artery spasm. So in that cases of patients, treatment with maximally tolerated doses of calcium channel blocker and smoking cessations are the most important. If it is medical therapy is ineffective, then go for ICDs. And third one is if they are resuscitated from the SCA due to coronary artery spasm, then ICD can, in addition to medical therapy, may be responsible for meaningful survival of greater than 1 year is expected. So these are very terminal cases which are almost returning from the death. They are just knocking the death door, either sudden cardiac arrest which was there, or when we are preventing sudden cardiac death. So in both cases, SCA, that is sudden cardiac arrest, and sudden cardiac death, they are the almost last stages, and the patient is almost coming back, just knocking the doors of heaven and coming back, what we call it as. So these are the conditions, and therefore these are particularly expected that even 1 year prolongation of life is a bonus in these patients, because they are almost died actually on the day of event. So any improvement into life is a bonus. If it is affordable, they can be done. The patient with left ventricular ejection fraction of 35 or less because of the ischemic heart disease and are having at least 40 days of post MI, means those who have survived 40 days after myocardial infarction and at least 90 days post revascularization, these are having this NYHA class 2 or 3 type of heart failure, and ICD is recommended if meaningful survival greater than 1 year is expected. Then whatsoever that guideline derived management therapies are there, but this is expected. ICD implantable cardioverter devices are the best one. The second thing is in the patient again where there is a ejection fraction is now again lesser than previous one, that is earlier it was less than 35, now it is less than 30%, due to ischemic cardiac diseases and who are at least 40 days MI survival or 90 days after revascularization and having class 1 HF, ICD is recommended in this also. So in all cases of this we can recommend this intracardiac or intracardiac devices. Then the transvenous ICD will provide high value in the primary prevention of SCD, particularly when the patient risk of death due to ventricular arrhythmia is very high, and the risk of non-arrhythmic death because of cardiac or non-cardiac reason is deemed to be low. And in that cases, if the arrhythmias are going to be major causes, then ICD is the best way. Patient with non-sympathetic this one ventricular tachyarrhythmias due to primary MI or where this left ventricular ejection fraction is less than 40% or less than or inducible sustained ventricular tachyarrhythmias, then this go for ventricular tachyarrhythmias, ventricular fibrillation at electrophysiological studies, and in all cases this ICT is recommended. ICTs are not recommended in NYHA class 4 people, that is last stage of heart failure, where the medication refractory HF is there, who are not also candidate for the cardiac transplantation. So we cannot do anything to them. There is no point in making any money on that or making any kind of treatment. There is no other option to go for no ICD treatment. Okay. So only CRT defibrillated in hospital, it can be there, it can be doing this defibrillation and pacing, having simultaneous activity, that much is okay, and the patient will be remaining to hospital. With ICD, patient can go out. So primary prevention of this sudden cardiac death in patient with ischemic heart diseases, we have already seen this. This is in the form of this algorithm. So primary prevention, having left ventricular ejection fraction less than 40. So if it is MI more than 40 days or after revascularization. What is revascularization? If MI you have studied, or if you remember what is revascularization, that when there was a MI, after MI we are supplying blood again. There is again blood flow is started either by drugs like streptokinase, urokinase, etc., or by angioplasty or by CABG. By any reason when we are causing it, then it is a revascularization. So after that we have to wait for 90 days. And if it is not done, myocardial infarction was there, it was sudden attack, you have prevented it, and then 40 days is enough. Then accordingly you go for various treatments and go for ICD in that cases. Then next is last option you can file. There is one more CD, that is WCD. WCD are the wearable, implanted, or they are put inside the arteries near heart, so that from that it will be there, and it will be there for at least 1 year. Well, wearable are the machine like things, just like our hearing machines are there with battery, something outside, and some electrodes which are outside, and these are called as a wearable cardioverter devices. So these are various devices which can be applied depending on the treatment. Go for the treatment whatsoever guideline suggest, and accordingly it can be there. And in most of the cases you will find that ICD is important. ICD has to be applied, and these are the instruments, these equipments are there which are put into arteries just close to heart. The treatment and prevention in the patients with ischemic heart diseases. So what are recommendations for the treatment of recurrent ventricular arrhythmias in the patient with ischemic heart diseases? Here the class of recommendation is 1 in all cases, so that is the first line of recommendation. Patient with ischemic heart diseases and recurrent ventricular arrhythmias with significant symptoms or ICD shocks, that is the ICD shocks are there despite optimal device programming and ongoing training. We know what is ICD. This is this implanted cardioverter device. This cardioverter device is, what it is doing is, it is releasing the impulses. So it is a small potential which is continuously released, and this potential is taken up by heart, and now on that basis of this potential the heart is pumping. Heart is not pumping on its own impulses, so that is AC node or AV node. Instead it is working on this. So since this is releasing small current over there, it may produce shock in some people, it may produce some current activities despite of good device programming and ongoing treatment with beta blocker. So in that cases, when there are such problems, then we can give beta blockers, amiodarone, sotalol, along with ICD we can give. The patient with prior myocardial infarction and recurrent episodes of symptomatic sustained ventricular tachyarrhythmias and who have failed or intolerant to amiodarone, other antiarrhythmic medications or catheter ablation is recommended. So there are many antiarrhythmic agents we have seen, class 1, class 2, class 3. So we have seen amiodarone was a emergency medication. It is not immediate one, it is not class 1 remedy, or it is not the first choice, but it is the first choice when there is an emergency. So it is an emergency treatment, and if it is not working, then go for other anti-arrhythmic agents. Then the patient with ischemic heart diseases and having ICD shocks are there, then for that catheter ablation is the first line therapy. It may be considered to reduce recurrent ventricular arrhythmias. The thing which should not be done, which is harmful or which has no meaning of doing, is a patient with the prior MI, the class 1C antiarrhythmic medications like flecainide and propafenone should not be used. This is very important. Then another harmful problem or harmful treatment can be the patient with incessants, that is very high ventricular tachycardia or ventricular fibrillation. The ICD should not be implanted until sufficient control of arrhythmia is achieved. Then only this should be there, otherwise it will cause repeated shocks with the ICD, and this is very, very important that first you should control it and then go for ICDs. Treatment and prevention of recurrent ventricular arrhythmias in the patient with ischemic heart diseases. There is a class of recommendation 3, that is there is no benefit or even no harm. This patient with ischemic heart disease and sustained monomorphic ventricular tachyarrhythmias, coronary revascularization alone is an ineffective therapy. So you must have another treatment, antiarrhythmic treatment simultaneously with it, like beta blocker or calcium channel blockers. So this is the algorithm for that, what kind of it and what you should do. That is, if you see it, if there is intracardiac this intracardiovascular device is put having in the patients with ventricular tachyarrhythmias, then check the arrhythmia status. If it is polymorphic or it is a sustained monomorphic, then accordingly go for treatment. If it is monomorphic, then what you will do is you check with the catheter ablation as a first line therapy, and otherwise go for amiodarone or sotalol immediately. If arrhythmia is not controlled, then again the first choice will be catheter ablation therapy, and in all cases you will find that catheter ablation, whatsoever consequences are there, if the arrhythmia is not controlled after that, after amiodarone and sotalol, then the only treatment remains is this. The second one is, if there is a reversible causes are there for that ventricle, then check the drug or any electrolyte which is inducing it. If it is so, then control these drugs or electrolyte which are inducing the arrhythmias. If it is because of ischemia, then cause the revascularization, either give the treatment like CABG, that is bypass, or coronary angioplasty, or go for the antithrombic agents or plasminogen activators, as we say, and go for that treatment and check it out. If there are no reversible causes, or we cannot identify it is there, or whatsoever identify we find that it cannot be there, then immediately go for amiodarone. It is a class 1, in that case emergencies. Then beta blocker or lidocaine can be given in some cases. If there is arrhythmia is not controlled, then identifiable various triggers are checked, which triggers are responsible for this ventricular arrhythmias, and try to remove this with using catheter ablation or autonomic modulation. This is how we are going for the treatment, particularly in non-ischemic cardiomyopathy. Okay, so NICM here is a non-ischemic cardiac myopathy. So these all we shall be studying accordingly. What are the treatment of NIS, this non-ischemic cardiac myopathy? So these are various recommendation and various classes which are asking for this. So we shall start this in next class. If you have any difficulties, you can put it. I repeat, please keep on reading anti-arrhythmic agents. There are so many anti-arrhythmic agents you studied in pharmacology, how they are used, how they are applied, in what condition they are good. This knowledge can even help in pharmacology, and pharmacology knowledge will help to this science. So be this one, be safe, be careful, and go for your studies.